Hello everyone, and welcome back to Network 27. I'm Alderman Walter Burnett, Alderman of the 27th Ward. I'd like to thank everyone who helped us to put this show together. I know we're into June, and a lot of the young people are getting ready to get out of school. You all can always touch bases and look at our website. We're always putting information on there, telling people about, or call our office and give us your email address, where we can send out things to you about things that's going on for the young people while they're out of school. Make sure they sign up for the one summer program for the summer jobs. Our number is 312-432-1995. So, ladies and gentlemen, we have a great show for you today. We're actually on site at Miles Square Health Center, and we have with us today. We have Dr. Robert Wynn. Dr. Wynn is a associate chancellor for community-based practices at U of I Cancer Center at the University of Illinois, and also he's the director of the U of I Cancer Center at the University of Illinois. So he wants to tell us about himself, Miles Square, tell us about all the free care that they have, and a lot of other great things that are necessary for people in our community to be healthy. So, Doctor, thank you very much for coming on to the show.
I appreciate it. Thank you.
Why don't you introduce yourself to the audience and tell them who is Dr. Wynn? And you have such a broad title. Maybe you can embellish upon that a little bit more.
Will do. So I'm Rob Wynn, Dr. Wynn. Got my medical degree from University of Michigan, Go Blue. And I'm actually here at the University of Illinois Health Center, and got drawn here because of the overall mission of this place. I am, as you said, Associate Vice Chancellor of Health Affairs for Community-Based Practice. That's a mouthful. But what that job actually comes down to, when you break it down, is really I'm in charge of the ambulatory services that get out to the community. So Miles Square happens to be part of that, which I'm incredibly proud of. That's the CEO of Miles Square is Henry Taylor. We have wonderful people here, Dr. Cameron Matthews, Sherry Peavy, and a lot of people who make it all work together. And working with them has been a pleasure in the context of making certain that health gets out to our communities for sure. The second role that I play is a director of the Cancer Center. As a director, I'm I think one of the only African Americans, sadly, that is in charge of a cancer center. But I'm actually excited about that too, because the opportunities of actually making certain that the science that goes behind the next miracle drug is happening here. Okay. And that we have this oversight of making certain that things are available not to just some people, but to all people, independent of whether their income is low or high.
Fantastic. So before we get into that, Doctor, because some folks may not know Miles Square, may not know where it is, may not know the history of Miles Square. Can you tell us a little bit about Miles Square and how it's connected to the university? Oh
yeah, it's a rich history, and it's a wonderful history when you think about Miles Square. It's wonderful for Chicago in particular. Most people probably don't know that as we even make our Miles Square is part of what's called the Federally Qualified Health Center. That was a movement from the 1960s, actually with LBJ. This war on poverty, which included health, was to actually have these federally qualified health centers that was supposed to be the undergirding for America so that all people had access to care. Now, people may not remember a time in America where, honestly, it wasn't easy to find a doc. And in fact, there were areas in Dorchester, Massachusetts, there were areas in Mississippi, and there were areas right here in Chicago where we had some of the worst outcomes of health, chronic diseases, highest mortality of infants, and these types of deals. Miles Square comes out of that federally qualified health center movement. Interesting enough, we are the third oldest federally qualified health center in the United States. The first was established in Dorchester, Massachusetts. The second one was in Mississippi, and the very third one was established right here in Miles Square.
Now, Miles Square used to be located on the west side, but over on Washington
National, yeah,
and not Washington, Washington and about Hoyne.
That's right. With the Henry Horner homes and all the rest of that. That's right.
Yeah,
that's right. Now the reality is, it's in that 50 years of Miles Square, it's gone through some iterations. It had a partnership with Rush way back when. People may remember. It has done plenty of things. I mean, in fact, Miles Square, we should all be proud of. At one point in the 80s, it became really the model of how other federally qualified health centers should be. The relationship between University of Illinois and Miles Square, however, is not as long as those 50 years. It's mostly 25. And that was an interesting sort of partnership, and came out of the fact that that the state university and at the time Mayor Daley and others had figured to make Miles Square really work, it probably needed an extra oomph and it needed extra resources. And the best way to do that was felt by the administration at that time, Daley, who really led the charge on this, and others, was to see if the partnership between the University of Illinois and Miles Square could not just revive Miles Square, but make it much more robust. And in that context, I think we've done a really good job in the 25 some odd years of this partnership. We've grown from the one site that you've talked about that was right around there, right around that Damon Henry Horner Holmes area, to now 13 sites.
Wow, so you have 13 sites.
We have 13 sites that are all over both the south and west sides of town. In fact, the nice part about that story is it's not just, everybody thinks of it just as a clinic. We have 3 varieties of what I call flavors of what Miles Square Access is. And one is the traditional flavor in which we have a clinic. And we'll talk more about what we're trying to do in advancing what federally qualified health centers are able to do. The second one is a school-based clinic. Now, people think of school-based practice and school-based health as a nurse that happens when you get a fever. They take your fever and tell you to go home. Well, this school-based is very different. That's led by C. Boyd Barnes, who actually had the vision of being able to say, what if we were able to take care of whole entire families after school is over? So at 3:30, instead of actually school closing down for after schools, it becomes now a place where everybody in that community can access real health in the context of our nurses or our doctors who are actually seeing them. And then the last is something called the Integrated Health Center. The Integrated Health Center is an interesting sort of model, and I think was absolutely on the innovative and leading edge when it actually got created, which was having a group of nurses actually take care of not just your primary care needs, but primary care needs in the context of those who are most challenged with behavioral health issues.
So Doc, so you were on Damon in Washington, then you moved and you all built this new building right here where we are right now.
Oh, yeah.
Now, where is this located?
Now, this building is on Roosevelt and Wood, and I would tell you, this building to me is the next step or the next level in the future of what I hope all FQHCs will be able to attain.
So FQATs.
Yep, federally qualified health centers.
All right.
Yep.
Okay.
And these federally qualified health centers, in general, people know them as Erie, Access, Circle Families, right? But these are all part of a network of federally qualified health centers that are supported by the federal government to ensure that people get access to health, even with very low incomes and in cases with no income.
Okay. So you say, so this is your main spot right here.
That's right.
It's bigger and better than the other spot, but you said that you have several others throughout the city. Do you have any idea of where any of those are?
Absolutely. So we have presence in South Shore, Englewood, back of the yard, Webb Davis. We have places in Cicero. So we have a number of places that are around town.
So you of I have a great reputation of creating new breakthrough cures for different things, and a lot of good scientists here, and you guys like on the beating path of making history in the medical field. So are those expertise and all of that great knowledge and resources, are they available all the way down to the clinic?
All the way.
All the way. So they connect. So people who go to your clinics are connected to everything that your hospitals and the university has to offer.
And that's the great partnership between the university and Miles Square, because we are one of 5 public entities in the entire United States that has this unique relationship where we're sort of operating arm in arm. The crazy part about that is the issue around sickle cell, for example. I don't think most folks know, but Dr. Gorduke and others with our sickle cell team has made the first, and I think Skip Garcia used to talk about this, we have now the evidence of the first ability to sort of cure sickle cell.
So all of the
With bone
research that you all do comes all the way down to the community level.
All the way down. In fact, we call it a bench community, meaning right from the bench where those scientists, the mad scientists are working, and those doctors are trying to actually come up with a miracle cure, getting it from that bench in that laboratory all the way down to the people. And that was the excitement of what brought me from Colorado here.
So although this is affordable health care for people who may be low income or no income, they still get the top of the line services and resources.
And that is the best part of what I get to do. I oversee the fact that if there is clinical trials that would be available to people from Abu Dhabi to the Gold Coast to Lincoln Park, that is also available to people from Pilsen. It's also available for people from any other in Inglewood. Yes, and that's the best part of what I get to do, and what we get to do as a university is making this stuff available to all people, regardless of where they come from, and regardless of whether they have low or no income. For example, in this building alone, this Miles Square building, the new building, we have an urgent care. Now, people might say, well, why would you put an urgent care in a federally qualified health center? Isn't that supposed to be primary? You know, you get something wrong with your, sore throat and you go see the doctor? No. Our attitude was we need to be on the forefront of this. So people in the neighborhood, instead of having to go to the ER and pay $800 to get your strep, screen for your sore throat that might be strep throat, might not be.
Instead of going to the emergency room.
Instead of going to the emergency room. Because for many people of low and no income, that is their primary center, which is why the costs are all being driven high, because we have not provided very, significant alternatives. One of the reasons of having federally qualified health centers in the community is because you shouldn't have to take 3 buses and a train to get health. Now that's maybe some 1950, 1960 sort of gig where you figured, well, if you didn't get it, you didn't get it, but that should not happen in the 21st century. And so we're ensuring as much as we can that our presence on the south and west side, that all of those federally qualified health centers that are part of the Miles Square are connected and accessible to all of what we have here at the university. I think that that's the nice part of what I get to do.
That's great, Doc. That's great. So tell me, what else is going on over here? I mean, so I know you do a big emphasis on the cancer, right?
Yes.
So what are some of the other studies and education and things that you are trying to get out with the community?
Yeah. So we also are pushing, and this is made possible, for transparency's sake, by the president's ability to put together the Affordable Health Care Act. There's much more focus now on what's called population management, population health. Another way of putting that is, how do we actually manage the health in the community? One of the ways we're doing that is that we're actually looking at that, not passively, but studying that. How do we, in addition to access, how do we let the community know what's actually happening on their campus? That's called the dissemination part. Lots of things happen to communities. We do research on communities, but we want to stop that in the context of and stop doing things to people and start doing things with people. So we, again, this morning I started off at a meeting in which we were informing the community about our activities around our research efforts and our clinical efforts. And we're trying to sort of say that it's not just about drug discovery anymore. It's about drug discovery and what we call scientific implementation. Another way of putting that, as my cousins would, if I were talking to my cousins, was taking it to the street, making it real. And actually giving the community an ability to sort of actually not only understand and digest, but be able to sort of question and push us about why you're not studying this. Those are the types of deals that we've been doing, and Alderman, I mean, just to, for the record, I mean, you've been doing a wonderful job in making sure that, the folks that are in your ward actually are getting that kind of information, and you're reaching out and to the university and sometimes pushing the university to sort of say, what are you doing, is part of that process.
Well, I appreciate that. So one of the things that you're really trying to do is trying to make sure people get tested and take advantage of being aware of different illnesses that they may or may not have, right?
That's right. For example, we know that cervical cancer, that in the United States, no one should die from cervical cancer. We know that. We have ways of treating it. We have ways of screening for it. We even have an HPV vaccine that
So
can prevent it right from the beginning.
what is cervical cancer?
Yeah, so if I was talking to my mom, she would say that's one of the women cancers.
Okay.
That actually
Maybe that's why
is part of the reproductive sort of system.
Okay.
And it's definitely a women's health issue in which
Okay.
the cervix, and most women know when they're going for their pap smear, they know exactly what they're doing when they get a cervix, when they're checking the cervix. But
Okay.
pap smears and all the rest of these things.
Okay.
We know that pap smears, HPV vaccine, and these types of deals can prevent cervical cancer from
So
even
it's
happening.
preventable,
Very preventable.
but they just got to get treated.
But in right here
Or
in
tested.
Chicago and in some of our wards, we have twice the number of deaths that we do from cervical cancer as we do in the rest of the country.
So unnecessary death.
Unnecessary death. And so one of the other big things we want to make sure is that we're partnering up with communities is that, this was Lincoln's institution. And so what Lincoln said about this is that we're not a public university, but the public's university. And in the context of being the public's university, we really want to make sure that we are partnering up with people who could use and have access to these wonderful sort of resources that we have here.
So there's a lot of other cancers. I think. What's the highest cancer that's that happens in the communities?
Yeah. So sadly, this is this is what happens when we sort of don't pay attention. But it turns out there will be more men dying from lung cancer and more women dying from lung cancer this year than any other. For example, more men, particularly African American men in this case, will die from lung cancer this year than if you add up colon, prostate, and pancreas all combined.
Is that right? And is that coming from what, cigarette smoking or?
The interesting thing, it's probably a combination of cigarette smoking. It's a combination, which we're going to not talk about the Lucy's, but I'm just saying that I'm not trying to.
So the
Lucy's, which are the as we say.
From the street, man.
I'm just saying.
So a lot of these folks don't know what Lucy's are.
So the Lucy's are what your kids would actually tell you in the context of buying single cigarettes.
Okay. I know what Lucy's are.
In this context of this practice of being able to say, well, our kids can't afford packs, but they can afford a single cigarette, also contributes again to the overwhelming sense of the contribution of lung cancer. Just to sort of say, again, this is the problem when you come from a 15-year-old mom and you come from the neighborhood. Sometimes as we start to talk, and I want to make sure that everybody knows that this is not some sort of academic thing that you have to be all prim and proper to talk about. This is real stuff happening in real streets. Mm-hmm. And so when we look at lung cancer, we look at also in this case, African American women. We'll take that for an example, but it's all women. African American women will die more from lung cancer this year than if you put in, again, colon, breast, and ovarian. And yet, where through our churches, where through our barbershops, our hair salons, where are we actually talking, our parishes, where are we talking about the issues around screening?
So getting screened, and that's the challenge. Folks don't get screened.
Folks don't get screened. In fact,
do they know to get screened?
That's a very good question.
Right.
Now, sometimes they know to get screened, but it's difficult for them to get the screening because they don't know where. Mm-hmm. I think almost everyone knows they should take care of their health. I think everyone knows they should eat right, and if they had access to better food, maybe they would actually do it. I think everyone knows they should get screened. All of us know, and especially some of us when you turn 50, you should be seeing a doctor, but most of you, right? So we know what we should do. The question isn't do we know, the question is do we have access, and is that access made easy?
Or affordable.
And so that's one of the fights that we've really been trying here at University of Toronto.
So you're trying to tell the people in the community that they can get screened, and it is affordable. They do have access.
Absolutely. And in fact, sometimes when they have no income, they worry, or they're undocumented. There are programs out here that will pay free, all of it, for you to be screened. So the truth of the matter is, these things are out here. What we have to do a better job on is connecting the people to those resources so that they can access it.
So cancer. I mean, cancer is a big killer in our nation, right? So you're saying some cancer can be avoided if you can detect it early on.
That's absolutely right. And there are women dying at early ages from cervical cancer, which never should ever happen. There are people dying from other types of cancers, particularly GI cancers, liver cancers in our Latino communities and Asian communities that, again, would be preventable with screening.
Mm-hmm. So is there anything else you think the public need to know about what you all are doing?
Oh, I do. I
know you can go all day. We got about 10 minutes.
I could go on and on to the break of dawn about this, because the things that are happening on and on to the break of dawn, because I'll tell you, the things that are happening here at this university actually is leading and shaping, I think, medicine within the 21st century. Mm-hmm. The fact that you have an academic institution that actually pays attention to the populations and the communities, you would say to yourself, that should have been happening all along. But we know that's not the case. The old model of the university was, you can get to us, and if you can get to us, then you can get access to us, and then maybe you might get help. Fantastic. That model we are flipping on its head, and we are sort of saying that model has to give way to the fact that people shouldn't have to take 3 buses and a train to get to us. We should figure out how to get to them. Part of that strategy is using Miles Square, but part of that strategy is making sure that we reach out to our aldermen and other community hospitals, which I know is crazy for an academic center, medical center, to say, what are you working and partnering up with other community hospitals? Well, that's where the action is. The best way to get health, we know this, and my mom didn't have to go to college to tell me this, but using her common sense, she would go, if it's close, people will do it.
That's right.
And the truth of the matter is, we want to make it so that we are helping community hospitals, we're helping aldermen and communities to say, if it's in your neighborhood, how do we help that to become better so that you can use it, so that you can stay within your neighborhood to get help. And the reality is, if it's not available in your neighborhood, then you can come access help right here at the university. That to me is a new model, because for decades we have always made it, get to the hospital, that's how you get healthy. We should stop that madness and talk about, how do you stay in your neighborhood with the good foods, health access, so that you can stay in your neighborhood, get the health you need, and when you want to travel, or if you need real special expertise, then it's available to you at your public university. That's the exciting part of what's happening here in Chicago. And in fact, you may say, well, it's not so sexy, and well, that should be happening. But I would actually challenge anybody in the context that is not what has been happening, which has been contributing to the overall poor outcome of our communities. And we're trying to make that experiment, that grand experiment, happen here.
Fantastic. So you said, so you all got several other things you're doing research on, you're trying to get people tested for, and your big thrust is trying to go out to the community instead of the community coming to you, reaching out to them, letting them know that it's available. I know right after this, I'm getting ready to sit down with your Director of Recruitment, Retention, and Community Engagement, Kareem Watson.
Dr. Watson is a bad brother too.
Mm-hmm. So Doc, it sounds like you taking your street smarts and using that to connect with people in the neighborhood, so they know to come and take advantage of all of this excellent health care and testing and all of the resources that you have. But also, you was telling me earlier, you going out, you networking with all the hospitals and all the clinics, trying to get them together so this thing can be offered all over the place, and you can utilize all of the resources that everybody else has.
Yeah, and that's the overall plan. And to that end, we actually had gone over to Cuba before Cuba came hot, and started looking at what they were doing and how does a poor country have better health outcomes than we do. And to that end, we actually got a recent grant. And we are actually going to have some of the folks from the Cuban Ministry of Health come over here for the next year or two with us, partner, and figure out how can we deliver better care to our communities better. How do we educate our communities better? Because if they can do it on a shoestring and have better outcomes, I know we can do it.
That's interesting. So I'd love to go over to Cuba with you and see how they doing this, man. See how that government does it.
Well, then this will be great, because
I don't need to see Castro though, but I'm interested in going on. I'm cool if I do see him, but it's not necessary.
Well, the nice thing is they will be coming here in June.
I'd like to be at that meeting.
And
like
later in June,
that. Yeah.
and we will make certain that.
So not only there with their healthcare, their education too. I mean, it's interesting how. You know,
That's right.
They make something out of nothing.
You know what I actually sort of say, real global health means that it's not just what we learn in the United States, taking it to another country, but actually literally looking at what's happening in India, what's happening in Cuba, taking the best practice and say, how can we bring that back to our neighborhoods?
That's right.
To sort of really get the best possible care. That's real global health. And so we're, again, U of I is on the cutting edge of that, because you would think someone would have done that model. We're doing it.
Well, we appreciate you thinking out of the box, Doc. So tell me this, if someone wanted to come over to Miles Square and they don't have insurance, what do they do? Do they have to have Obamacare, or do Obamacare automatically kick in?
Yeah. So if someone doesn't have insurance, the first step is exactly what you just said. Come on over to Miles Square or wherever. You know, we want you to get help wherever you can get help from. But in this case, you've come to Miles Square. We'll have people to find out whether you actually can qualify for the ACA, or Obamacare as we call it, or if you don't, you can still be seen. Mm-hmm. And that's the beautiful part of what I get to do, because it's agnostic about we don't do a biopsy on your wallet before we have to be able to take care of you.
Okay. That's pretty good. Fantastic. So you saying everyone should get tested for not just cancer, but for everything every year.
And that diabetes, the high blood pressure, which we know plagues all of our communities, all of these things. And in fact, the nice thing about it is we have telephones. And in fact, if we give you information about, you can look on the website and put it, where should I get screened and at what age? And now all of a sudden, everyone has a phone. You have access to the phone. You have access to knowledge.
Mm-hmm. So is there any website, anything that people need to go to? You have any suggestions?
Yeah, there's several. I sort of usually tell people that there are competing things. There's lots of websites that are really good. MD, Outlook, lots of other things that are good. Most of the thing I will tell you to do, though, is whatever information you get from the internet, please check it with a physician or a nurse.
Okay. I got you. Well, Doctor, I want to thank you very much. I know Kareem's getting ready to come on. He's going to tell me about some events that you all have coming up with the community and how you're going to engage. I think it's very smart of you to put a team of folks together to get out there and reach out to the community. And I thank you for coming. I mean, we're having this show right now because you came to my office. And you sold me on trying to reach out to more people in the community, because you think it's very important to try to help people be healthy, get tested, yes, and prevent losing their lives. Yes. And this is basically a lifesaver.
Yes.
If you can stop somebody from getting cancer, or prevent them from dying from cancer, it's very important. And cancer is a big killer. So many people are dying from cancer. So I just want to say, God bless you, man. And
thank you.
Thank you. And we blessed to have somebody who know how to reach out to the hood and talk to the hood, man. I think that's important. Keep it simple.
Keep it simple.
Keep it simple. So God bless you, and thank you very much for coming on to the show. And again, ladies and gentlemen, I'd like to thank my guest, Dr. Wynn, Robert Wynn, who's a associate chancellor with community-based practices here at the University of Illinois, and he's also the director of health and hospital science systems. And he's doing research, but he's also trying to do research to get the community more engaged into taking care of their health. So we just want to thank you very much for coming on the show. Ladies and gentlemen, don't go anywhere. We'll be right back with our other guests. Thank you. Thanks again, Doc.
Thank you.
God bless you, bro.
Thank you, man.
All right. Thank you, ladies and gentlemen, for watching Network 27. I'm Alderman Walter Burnett. Remember that Network 27 has a new slotted time, which is 9 p.m. to 10 p.m. every second and fourth Monday, 9 p.m. to 10 p.m. All right, everybody, and welcome back. Alderman Burnett again with Network 27. Thank you all for coming back. So I said we have our second guest, which is Kareem Watson. He got all these letters behind his name. He's an MPH and an MS. And Kareem is the director of Community Engagement, Research, and Implementation Science with the University of Illinois. So Kareem, first of all, tell us what those initials mean, MPH and MS and...
Right, so thank you. First of all, thank you for having us. It's been a pleasure to be here. It's been a pleasure for Dr. Nguyen, who is our Cancer Center Director and also our Associate Vice Chancellor of Community-Based Practice. It's been a pleasure to work with him as we implement his vision for community engagement and how we can really bring the screenings and the treatment that's needed. But to answer your question, what all those initials mean, and it's important for us to talk about those initials, particularly to young people, and what those initials mean, because sometimes those initials are just letters, but they also can serve as keys to open some doors for us really getting opportunities. So I'm one of the people that's really interested in how do you do things at the grassroots level. So I have my doctorate in community health sciences and global health, thinking beyond just what's happening in Chicago, but thinking about how do the health disparities that exist impact us as a larger, as the world, right, as a nation. And then also I have a master's in public health and community health sciences. And I'm also a little nerd at the end of the day too. So I have a master's in basic medical research. So that really allowed me to think about what's happening at the lab. So what those letters do for me, and I tell young people this all the time, it really allows me to have a conversation from the bench to the community. I can understand what Dr. Nguyen is doing in his lab when he's looking at what's happening in lung cancer and how at the biological level and the cellular level and the molecular level, something different may be happening in certain populations that don't happen in others. That's what my Master's of Science in Basic Medical Research does. And then my MPH and my doctorate lets me think about, now how do I take that message to the community? How do I create messaging? How do I create programs that can let us understand what's happening to us and how there may be some differences? So for example, if you think about clinical trials, there's a lot of medical mistrust out there, and rightfully so. You know, we had Tuskegee, we had other things that happened to us that weren't so great. But then if we still continue to have that medical mistrust, how do we then create programs that are really addressing the needs that we may have, because we're all different? So all these letters help me do that.
Great. So you're the guy who go out on the street.
Yes, that's right.
So why don't you tell us what you're doing and how you do it?
Yes. So when Dr. Nguyen came on board, the one question he asked us is, how are we engaging with people just like you? How are we engaging with the aldermen? So you look at a lot of communities around the states, and we all think about how our health disparities, and health disparities are something simple as just things that are happening in one area that may not be happening in the other area. Health disparities are the fact that you look at breast cancer rates in the Gold Coast versus breast cancer rates in Roseland and breast cancer rates in the South Side, and they're different, right? Even though women may be getting cancer at the same rate, their outcomes are different. That's what we call a health disparity. And so one thing he asked us and challenged us to do was to think beyond the zip code. We did a lot of data around zip codes, saying that this is what this zip code has, these are the disparities that exist in this zip code. But he said, where's the conversation happening at the person that can really drive the change? People just like you, right? So you have this great network here, this great forum, but you can actually have conversations with your constituents on a regular basis. So how are we, as a cancer center, as a university, arming you with the information that you can have conversations about what's truly existing at your community level? So when he asked us that question, and what are we doing, the answer was, at the time, not much. So the first thing we did was we partnered up with the city and with the state and with some epidemiologists here at UIC, like Dr. Vince Freeman, to think about how do we take data and turn that data into something that you can use to have conversations with your constituents. So the way I take it to the street is, first of all, I let people know what's existing. I let them know what are some of the disparities in colorectal cancer, what are some of the disparities in breast cancer and prostate cancer, and then also very important and not often talked about is lung cancer. What are the disparities in lung cancer? But we don't want to just be doom and gloom. So once we talk about the disparities, because a lot of people are talking about what's lacking, but not a whole lot of people are talking about the assets. So what do we have in the community that can help this? And we have Miles Square. And Dr. Nguyen sits in a unique place in being over both the UI Cancer Center as well as serving in his capacity over all of our 13 sites for the Miles Square Health Center. How can we leverage that to really begin to address community needs? And so I get a chance to do that. I'm blessed to do that every day.
Fantastic. So what type of things do you all have coming up?
So one of the things we have, I'll talk about one of the programs that we're actually going to be working with you on, and that's we're in the month of June. So June is actually Men's Health Awareness Month. A lot of people don't know that because we think about Mother's Day, and we have all these initiatives around Mother's Day, but Father's Day comes, we go get a tie, and we call it a day, right? So how can we...
Or socks.
Or socks, if you're lucky, or just a day off. But how can we use this concept of men's health? Like you think about a car, right? You know, we get our cars washed, we get our cars tuned up, but as men, we don't often take that same pride that we have in the vehicles we drive. We don't take that same pride to our
On
health.
our body, isn't
or
that
our
something?
bodies, right. So we keep our cars up, but not our bodies up. So how do we have a conversation with men in the barbershops, in our churches, in our other faith places about men's health? And so in the month of June, you're going to see us out in the barbershops talking about prostate cancer screening, talking about men's health screening. You're going to see us in your ward talking about colon cancer screening, prostate cancer screening, lung cancer screening, and where you can get these screenings. And also not just where, but why you should be getting these screenings. For example, prostate cancer screening. There's a lot of myths out there about men saying, well, I was told that if I get this, that getting the screening causes more problems than not getting screened. That may be true in some communities, but not in ours. Because if you look at one of the communities in your ward, in some parts of East Garfield Park, you have men dying of prostate cancer rate at upwards of 3 times what's happening throughout the rest of the city. So that means that we, unfortunately, still have to have conversations about prostate cancer screening. You talk about what's happening in the community. I know Dr. Wynn talked about Lucy, single squares. Well, that's being sold in our communities, but if you go to other neighborhoods, you're not having that same conversation. That's a policy issue, right? That's what we need to talk to you about. How can we address that from the policy level? Why is it that you can get, Black and Milds, other, swishers from the neighborhood stores in some communities, but you can't get those same cigarettes in other communities? Why is that taking place? And that leads itself to higher rates of lung cancer and other conditions in our community. So throughout the month of June, we're going to make sure that people are aware that you can talk to us. We can navigate you to screening. Like, for example, every second Wednesday in Miles Square, a woman can come in for a mammogram, whether she has insurance or not. It's a program that we developed called Walk-In Wednesdays.
Walk-In Wednesdays.
Walk-In Wednesdays. And we built on the second Wednesdays of every month. Because when Dr. Wynn came on as well,
so they can come get a mammogram for free?
For free. If they don't have insurance, we partner with the Metropolitan Chicago Breast Cancer Task Force. And through that partnership with the Metropolitan Chicago Breast Cancer Task Force, they went around the city to actually partner with other hospitals that had those hospitals donate screening mammograms to this task force. And through those donated mammograms, we're able to navigate women who are uninsured or underinsured to free mammogram despite their ability to pay. And something we're very, very proud of.
That's great. So mammograms deal with breast cancer.
So that's for women in breast cancer.
Yeah, and a lot of women die from breast cancer.
Yeah.
And it can be prevented.
Totally prevented. My own mother, I do this work because it impacted me personally. My own mother died of breast cancer. And
sorry to hear that.
Yeah, and through the work that I was doing in the faith-based community, I was doing a program called Pin a Sister. So we're now in June, but in the Mother's Day, there's a program called Pin a Sister. My oldest sister was actually diagnosed with breast cancer through a program that I was doing at a local church. That program had women to stand up and take a pledge to get a mammogram. My sister happened to be visiting. She was one of the women that stood up and took that pledge to get screened. And when she got screened, she found out that she had breast cancer. But her outcome was different than my mother's outcome. And so I tell people all the time that I feel like my life is the amen to prayers that were prayed long before me. Because what happens when a mother, such as mine, loses her life to breast cancer? I believe that mother makes a prayer. And she says that although my life is lost, my mission has to go on. And so through everyday work that I'm able to do, I'm able to carry her mission forward. So she may have lost her life, but every day I win the battle because I'm able to make sure that women in our community, that sons have different outcomes than what I had, right? That they don't have to lose their mothers early. Because my nephew still has my sister here because of something we were able to do. So I'm thankful. Sometimes I'm surprised that I get paid to do this.
So you feel like you should be paying them to do it.
Sometimes.
Yeah, don't cut your raise out.
No, I won't. I work very hard.
That's good, man.
And I'm excited about the work we're going to be doing with you too. So we have a new team member who's been with us for a while now, named Jonah Anderson. He's been working with us to really build up our partnerships in barbershops, our partnerships with you, our partnerships with other civic leaders, to think about how and where do we have the conversation with men. One thing Dr. Wynn has cautioned us about doing is having conversations with the same people in the same places because they haven't worked.
Dig that.
Yeah, you know what I'm saying? So if we always build this model up where you got to come to us, that has not worked. And so to continue to do it would be unethical almost, right? So we're now thinking, how do we have conversations and who do we have those conversations with to bring men to the table to get screened? That's why I'm really excited about the program we're going to be doing with you because it's going to be in the community. So how do we have the conversation in the community and then provide the resources at the community level to navigate those men to the place where they can get the screening and care that they need?
Great, fantastic. That's good. So what else you have coming up? So we're looking forward and looking forward to getting this information out to the community so that they can come and get screened.
Yes.
Get some free screening and find out if something's going on and try to prevent it.
Yeah, and then the other things we have going on, so while we talk about the men's health stuff, and that's happening in June, actually we're very fortunate. Every month there's some program dedicated to cancer screening, awareness, and prevention. And some of those months we know about. For example, we know that we know a lot about October being Breast Cancer Awareness Month, right? So this city goes pink in October for the most part, right? But do they go blue? No, I'm a Michigan fan too, so go blue. But do they go blue in June for men's health? The answer is no. Do we even know when Lung Cancer Awareness Screening Month is? Do we even know that March was Colorectal Cancer Screening Awareness Month? So we can be working year long to make sure that every month we're bringing awareness to the community. Like we have a colorectal cancer screening project, one of the few in the city, where we actually can provide free colorectal cancer screening for people that are under or uninsured as well. Because colorectal cancer screening is one of the few screening tools that can be screening and prevention. For example, when you get a colonoscopy, if they find some abnormal polyps during that colonoscopy, those polyps can be removed. And that once those polyps are removed, they can go back to the lab and they can find out that those polyps may have been precancerous. So in that screening, we actually did some prevention as well. But we have to have these conversations at the community level because, we start talking about screening with men particularly, we get a little uncomfortable. We start talking about colonoscopy, I don't know if I want that. We start talking about PSA screening, and then what also goes with prostate cancer screening, they say, I don't want that. Yeah. And this is one thing I told my own brothers.
Men are worried about that rubber glove.
Yeah, when men tell me that, I say, you're worried about the rubber glove, but you're not worried about the silver knife.
Dig it.
Right. The glove is less invasive than the knife.
Dig it.
And although we've made a lot of advances in prostate cancer treatment, you still don't want to have to go into that surgery.
So sometimes they can find out just from blood though, right?
Exactly.
Right.
So there's a blood test actually for prostate cancer screening called prostate-specific antigen, PSA. Mm-hmm. It's a test that you want to look at to see what that number is.
So they don't necessarily always have to have the blood?
We do need the blood because the blood begins...
necessarily always have to have the glove.
Not the glove, not always necessary. No,
right.
It's, and it's a conversation.
Because I think that hold up a lot of men.
It does. When we want to tell every brother, come on in and have the conversation. Everything we do, all the screening that we do, all the education that we do, it all starts with a conversation first. It starts with a relationship and a conversation. Through that relationship and that conversation, we're able to say, what do you need based on your family history and risk factor? I'm under 50. I'm just turned 40, but I had to get my colonoscopy early. Why? Because unfortunately my dad died from complications of colon cancer. So I had to get screened starting at age 35.
So you think everyone, if you have if it happened in your family, that you should get tested?
You should be having a conversation with your doctor, and ideally with the primary care doctor, because there are certain questions that doctor, he or she can ask you that can determine when you get tested. Another program that we have here that we do at Miles Square is a program called Heritage. Heritage is actually helping educate about risk and informing genetic education. It's a program that we partnered with the genetic counselors here at UIC and UI Health, that we say, what things have happened in your family? When did they happen? And what screenings do you need based on what happened in your family? And we call it first-degree relatives. So if you've had
first-degree
relatives.
Relatives, wow.
And we don't have these conversations. We need to have them at family reunions. We need to have them on the basketball court. So we, in the black community is something, and I'm learning too, it's also kind of taboo in a lot of our brown and Hispanic Latino communities too. We know that Aunt Susie died of something, but we don't know what Aunt Susie died of when she had the cancer. Okay, she had cancer, but what type of cancer did Aunt Susie have? How old was she when she got it? What stage was it? All these are important conversations for us to know.
And then did grandma have it?
Did grandma have it, right?
Grandfather have it?
Right.
And could it have been prevented?
And the answer usually is yes.
Yes, it could have been prevented.
Yes.
So I know everyone talks like there's no cure for cancer, right? But nobody ever really say that there's prevention for cancer.
And that's that's
you know what I'm saying. Everybody think they think you're gonna get cancer and it's over with, right?
Yeah.
And so they so I think because of that, I think in some people's minds, folks are like, I'm scared to get tested because if I get tested, I find out, and then it's over for me.
Yeah. See, now you're getting into my public health world. So you're becoming a public health expert. I mean, this is right before our very eyes. You're absolutely right. In my world, we call that fatalism. Fatalism. And what fatalism in public health means is that I will not go get screened because I think that it's going to happen to me anyway. And if it happens to me, there's nothing you can do about it, so I may die from it. Fatalism was really big with lung cancer, right? People thought that if I smoked, and I smoked this long time, I ultimately may get lung cancer. It's not always true. And so they thought that the treatments were not going to happen because most people that they saw in their community, they saw someone get lung cancer, and they were right. The person that they saw did die. But the question is, why did they die? They probably died because A, they got diagnosed at a late stage 3 or 4. They probably died because B, they didn't have a specialist that they could talk to, and they probably died because of C, they didn't talk about a clinical trial. Was there some intervention that could have happened or could have been used in their cancer that wasn't available to the larger public yet, right? So again, that conversation. And so when I start talking about lung cancer, Dr. Wynn has been having this conversation about being diagnosed at stage 1 versus stage 2 and how that can drastically change your outcome. For example, if someone's diagnosed at stage 1 lung cancer, they're likely to go on and live a normal life after being treated and live and be fine versus being diagnosed at stage 4. So this whole concept of cancer being an end-of-life conversation is totally not the case anymore.
Not the case.
It's not the case.
So everybody should know that. But you know, like I said, a lot of folks just are afraid.
Yeah.
I mean, and you know, it's the same thing that you find with folks with HIV.
It's the same thing,
right?
Yep,
They're
yep.
afraid to get tested for HIV because they're scared if they get tested for it, they're gonna find out they have it.
Exactly.
And then they're scared their life is over.
Yep. And so as Dr. Wynn alluded to earlier, we don't have the luxury of a cancer center or as community-based practice of just talking about cancer. We have to be able to talk about all of it. And people are surprised. People are often surprised when they find out that our cancer center supports a program called the Faith and Clergy Lay Leadership Response to HIV/AIDS. Why do we as a cancer center support HIV screening for HIV/AIDS? Because if you get diagnosed with HIV, you have a compromised immune system. That compromised immune system puts you at risk for other things,
For
cancer and everything else. Lots of GI cancers, anal and rectal cancers in some populations. So we don't have the luxury of just talking about cancer. We have to talk about diabetes, hypertension, asthma, COPD, and everything because we don't have the luxury. But you're absolutely right. Young people are dying from HIV and AIDS, and they don't have to.
They don't have to.
Because if you get diagnosed early, get your levels undetected, you even prevent your ability to transmit the virus to somebody else. But we're not having those conversations with young people. And like I said earlier, screening for us, prevention education for us, it starts with a conversation.
And sometimes, and most of the times, all it is just taking a blood test.
Yeah, and
just get a blood test, and you can. I mean, in the blood test, they can figure out all that stuff.
But part of the problem in that, and I do want to own what we've done as the medical community. Part of the problem is that we've only talked about the problem. We haven't talked about what we can do in terms of solutions. All we've talked about is what we found out that was bad, but we haven't talked about things that are good. If you talk about HIV, we don't talk about PrEP. We don't talk about the fact that research has now shown that that you can take a medication if you're HIV negative that can possibly prevent you from contracting HIV by taking this pill every day if you engage in risky behavior.
I never heard of that one.
Yeah, pre-exposure prophylaxis, PrEP.
Oh, I never heard of that. So
yeah. Then it's also a post-exposure prophylactic, meaning that if you did engage in some risky behavior, you had a Friday night, that Friday night went away, you wasn't expecting it. There's a conversation you can have with a doctor about, is there something I can take that can decrease the likelihood that I will go on to develop HIV?
That's interesting. I never heard of that. So, you know, those kind of pills may make more babies be born in our
that's a different conversation. So it's several conversations we have to have, you know. There's the condom, there's PrEP.
That's right.
They're not exclusive conversations.
Okay. That's interesting, man. So I'm learning something here, man. I never knew that.
Conversations lead to learning. That's what we're about.
And the thing about cancer is that it don't discriminate against anyone.
Not at all. Not at all.
For minorities, low-income folks, that's to our benefit in a sense because a lot of people donate to it.
Right.
Right? Because it don't discriminate against anyone, a lot of folks donate to
Yeah.
it. And there's a lot of money that's going into cancer, that's going into prevention, that's going into research, right?
Yeah.
And everybody can benefit from it. We just got to take advantage
You gotta
of
take
it.
advantage of
And
it.
we're not taking advantage of it.
But I
and
don't-
there's so
yeah.
much money coming into it, you know, from private industry. People lose their parents, they donate to cancer.
Yeah, it's money coming into it, but again, I wanna take onus for what we've done. You know, we haven't always made it easy for the community to take advantage of it. We haven't had critical conversations as to why someone's not getting screened. Right? Let's talk about HPV. HPV is a virus, human papilloma virus, that is in most cases causes about 92% of cervical cancers of the cervix in women. So we have now a vaccine for HPV. But we don't have so we talk about HPV virus causing cervical cancer. We talk about the vaccine being able to prevent cervical cancer, but we don't have the conversation about why are mothers and caregivers and some fathers not getting their children vaccinated. We don't have that conversation. And the conversation is similar to the Tuskegee conversation. It's about medical mistrust. It's about, we haven't, as the medical community, we haven't had a conversation critically talking about the risk and the benefits of vaccines, right? Because the HPV conversation is no different than the flu vaccine conversation. It's no different than other vaccinations that you can take. Because in underserved, low income, and some racial and ethnic communities, vaccinations are low across the board. Because this one lady told me, she said, Dr. Watson, getting a vaccine is a luxury. And I was like, huh? How is getting a vaccine a luxury? And she said to me, that's something I'll never forget. She said, because you're telling me to get a vaccine to prevent something I don't already have. I already have this gas bill I can't pay. I already have this phone bill I can't pay. So I'm thinking about everything I can't do. And you want me to think about something that you want me to prevent? She said, it's a luxury to think about prevention. And it totally changed the way I thought about it. I never viewed thinking about prevention and public health prevention as a luxury. But it kind of is, right? Because that means I'm at a place where I can think about something about what I don't have. But she's too busy worrying about just her daily activities. So we got to have these critical conversations. We got to have these conversations with mothers who say, you know, I was reading on the internet and I saw that this happened with the HPV vaccine. That's not necessarily always the case.
So that's why you guys are so passionate about this.
It is.
You and the doctor. I mean, when the doctor came to see me, man, it's like this dude, he just kept talking and talking and talking and talking and talking. You know, he's so geeked up. I'm like, God, dog, what's going on with this guy? You know,
he's from the
really
community.
Just want his program to go or what?
No, it's you got people
because it's something that you can give and you can help and you can save lives.
It's something
and
that we've
not
lived.
taking advantage of it.
And it's something that we've lived. We don't do community engagement and community-based practice and because we heard that it's popular or because it is popular now. We do it because we've lived it. You know, when he talked about his story, he grew up and he grew up in the same communities being treated in a clinic just like this, right? So I grew up in a town, Muskegon Heights, Michigan. That was a small town, primarily African-American town. We had one black doctor in that entire town. So what does that mean to a kid like me? If I don't see people doing this type of work, people that look like me, people that speak like me in these positions, as a child, do I think I can grow up to be this? And the answer many times is no. But fortunately, I grew up saying, I don't care what I don't see, I still can try to be something, right? But so it's important that we do this work because we are from these very communities. And then youth engagement is important as well. So when we put Dr. Wynn's story out there, it's not just to put his story out there, but it's so that some other little boy who grew up with a mom that was 15, who everybody said that you can't do it, everybody might have written him off, can say that, no, you ain't got to be written off because there's somebody that had a similar story as you that went on to be one of the first African-American cancer center directors in the country.
So Watson, we're going to have to go. We got about 5 minutes left. I want to thank both you and Dr. Wynn for your passion, for your concern, how you care about our folks and want to give people an opportunity to live. Tell people how can they engage with you all more if they want you, let's say if they want you to come out and speak to their church or speak to their group or get involved in their neighborhood, what could they do?
Yeah, so if you want us to come out, that's exactly what our office does. If you want us to come out and talk to your groups, talk to your schools, talk to your children, your faith groups, just give us a call at our office at the UI Cancer Center at 312-355-5176. And I'll repeat that number is 312-355-5176. 888-888-5176. You can also send us an email if you're online. You can send us an email to my direct email at kswatson@uic.edu. And then you can go on the web and find us. Our cancer site is listed on the web at cancer.uillinois.edu. So invite us out. We got a team, and if the need grows, that means our team has to grow. So I go to my boss and say, look, we're getting a lot of requests. We need more people.
Dig it. So we got to make this team grow.
We do.
Yeah, because I mean, all these things that you can find out that can help people save their lives.
All of them.
It's incredible. And, and I take it for granted because, so like, and I just give you an example. I knew when you get around 50, you had to start doing the prostate cancer thing, right?
Some men even 40.
Some men earlier. But I knew, because of my stressful job, that I have to get a checkup every year, right? So I have to get a checkup every year just to see what's going on with me. So I just automatically get it, right? And I think a lot of older folks, as you get, I shouldn't say older folks, but as you get, become middle age, you start thinking more about checking yourself out, if you had that opportunity. But when you're younger, you think you're indispensable, that, I don't need to go to a doctor, I'm cool, right?
Right, it's true, it's true.
It hurt, it burns, it'll go away, right?
Right.
You know what I'm saying?
And sometimes it will go away, but the damage has been done.
That's right, and so we all need to take advantage of it.
That's right.
And we don't need to just look at grandma or granddad who go to the doctor all the time, but we take them to the doctor all the time, but we don't go.
Right.
You need to go too.
You do.
And it may help to save your life.
Yeah, and save our communities too, because every time a father dies, that's a community without that male influence.
That's right.
Yeah.
That's right. Well, man, I just want to say God bless you all for what you all are doing, and thank you for reaching out to the community and letting them know and being so passionate and
And thank you too, because there's not a lot of aldermen out there as vocal as you and really taking a stance and providing a place and a space for these conversations to take place. So kudos to you as well. I mean, you're at the forefront of this, and we acknowledge and we're proud to partner with you.
Well, I appreciate that, and I every time I bring you guys on, I learn something. I learn so much more. So what's that? The what was it?
HPV.
HPV.
Human papilloma virus, which causes a lot of cervical cancer.
All right, and then the other pill that guys take.
PrEP.
The PrEP.
Yep, pre-exposure prophylaxis.
Pre-exposure prophylaxis. But you still should wear condoms.
You 100% every time, all the time. I don't care what they say.
So the pre-exposure prophylaxis can stop you from getting HIV.
It can. Well, it can decrease the likelihood.
Decrease the likelihood before, and then there's another one called
post-exposure prophylaxis. So if you've been exposed, you should go and then talk to a pharmacist or your doctor ASAP. I mean soon, about seeing if there's a pill that you can take.
But the best way is to use prophylaxis.
The best way is to
use condoms.
I almost said something, but to use that condom every single time, all the time. I almost said what we do with our seatbelts, but
All right, hallelujah. So hey, young fellas, young ladies out there, take advantage. This cancer thing is the worst thing in the world. Once it hits you, it's hard to fight it, right? So there's opportunities to prevent it from happening.
That's right.
Helping people to live longer. And those of us who have family members who have suffered from it, we don't want no one else to suffer from it.
Agreed.
So just take advantage and let everybody know that you don't have to. Get tested, get a blood test, Take advantage of these free resources. There's ways to pay for it if you can't pay for it. But just come to Mile Square, and Mile Square, the main Mile Square building is located on Wood and Roosevelt.
Yep, 1220 South Wood Street, right on the corner.
And then, or you can look on the internet or call and find out where other free health care services are throughout the city of Chicago.
That's correct.
So there's no excuse.
None.
No excuse. So if things happen to you, it's on you. Right?
It's on us.
It's on all of us, but it's on us to let people know. Right, and it's on you all to take advantage of the situation. So we're putting it out there, so take advantage of it. So I want to thank you very much, Doc.
All right.
Keep up the good work, man.
Thank you.
Love your passion, man.
Right.
God bless you. God bless the other doctor, and thank you, UIC, for taking all those great resources, the research, the discoveries and putting it right back in our neighborhood. Thank you
appreciate
very
it.
much.
Thank you.
And thank you, ladies and gentlemen, for watching Network 27. I'm Alderman Walter Burnett. We want to thank everyone who helped us to put the show together. We're signing off. We'll see you next month. God bless.